Good evening, everyone, and welcome to our 25th PD in Your Pocket. My name is Elizabeth. You might recognise me from previous sessions. I haven't been with you the last couple of months, so I'm very excited to be back with you this evening for this very important topic. I can see people still coming in. Welcome, welcome. Okay, so while we wait for a few more people to join us, we might go through a bit of housekeeping. Before we do housekeeping, I'd also like to acknowledge the traditional owners of the country on which we meet this evening. While we recognise that we're on many different lands tonight, everyone joining us from home with many different traditional owners, I'm currently presenting from Gadigal country, and I'd like to acknowledge them and recognise their continuing connection to land, waters and culture. And I'd like to pay my respect to the elders past, present and emerging. I also acknowledge that Aboriginal families have cared for and educated children on this land for tens of thousands of years. We'll now just go through a little bit of housekeeping, just a bit of a run through of our PD in Your Pockets, the way that we do things for those who are new with us this evening. Last week when you registered, we would have sent you out the booklet. So hopefully you've been able to have a read for that. If you haven't got that, it's no problem. It will be on our website for you to read. All of our resources, so the recording from this evening, our interview and the booklet will all be up on the website in the coming week. So you will be able to access those. So we have our session tonight. We're due to go until 8:45 this evening, which does allow time for questions as well. So if you have any questions, you're welcome to ask those at the end of the session. And we'll also be having our usual interview as well. If you haven't already, I'd like to invite you to join our Facebook group. It's a closed Facebook group with lots of other educators from family daycare. So you can discuss tonight's topic or previous topics. It's a great place to network and have a good conversation about what we go through in each of the sessions and share what you're doing at your service. I know it's really great when family daycare educators can network and see what we're doing and see other people's practice and services. If you have any questions about PD in Your Pocket, you can always email info@nswfdc.org.au. Okay, now when you registered, we did ask you some registration questions, and we've put some information together from those questions to share with you about what we've learnt from you as educators. So the first question we asked is, do you have a child in care who is diagnosed with asthma? And the results are on the screen there. So no, 70% do not and 30% do. So that's still quite a large percentage of you with asthmatic children enrolled in your services. 30%, so that is quite significant. So again, very important topic tonight, looking at asthma, anaphylaxis and allergies in family daycare and how we can make sure that we're managing that to the best of our ability. The next question we asked you was, do you have a child in care who is diagnosed with anaphylaxis? So 84% of you no, and 16% of you yes. So again, 16% is still quite significant, considering that we're dealing with a life-threatening reaction here. So really important that we know how to respond to that. We then asked you how confident you currently feel to administer first aid for asthma, allergies and anaphylaxis. 49 of you were somewhat confident, 40% of you were very confident, 10% not very confident, and 1% not confident at all. So hopefully by the end of tonight's session, you'll be all feeling very confident in what you need to do as an educator and how to keep the children in your care safe. And finally, when did you last update your medical conditions management policy? And that is a very important policy that we will be looking at this evening as well. 88% of you said in the last 12 months, so fantastic, well done. And 12% of you said over 12 months ago. So possibly after tonight's session, it might be a policy that you're quite interested in visiting and looking at what you currently have in there. And hopefully some things from tonight's session will inspire you to maybe make some improvements or updates. Okay, so what are we going to be covering tonight? We're going to be looking at the management of asthma in family daycare, as well as allergy and anaphylaxis management. We're going to look at the laws and regulations around medical conditions for compliance and best practice. And that's really important to make sure that we are meeting compliance on such an important topic, but also looking at best practice. So stepping away from the regulations and looking at the best way to do things in our services. We're also going to look at what the National Quality Standards say, very important guiding document that should guide our practice. First aid training requirements for educators, because we do get a lot of questions about what's required of first aid, or what's required of educators in regard to first aid, especially for family daycare. Any documentation that's required, and we know there is a lot of documentation. I'm going to take you through a lot of the forms that are involved in asthma, anaphylaxis and allergies, looking at which ones are required either for a specific child or required for the service in general, about the general care of the children or the group of children. And then also looking at administering medications, making sure we know how to do that properly. Okay, well, it looks like most of you are with us now, which is fantastic. Hello to those who have just joined us. And we will get started. So we've broken the session up tonight because there's going to be so much information for you, lots of great information. And again, for those who missed it, the booklet and tonight's recording and the interview will all be on the website in the coming days. So if there is anything from tonight that you want to revisit or have a look at again, you can certainly do that. So the first thing we're going to look at tonight is all about asthma. So why is asthma management so important? Now, according to the Australian Institute of Health and Welfare, 1 in 10 children in Australia suffer from asthma. So that's a pretty high statistic when we look at that, 1 in 10, considering that a lot of services, you know, have 5, 10 children. So it's important that we know how to respond. It's unsure why children develop asthma. We're still not sure why some children get it. It could be hereditary. It could be due to the child being exposed to allergens or triggers from a young age. And as family daycare educators, it's likely that at some point you may need to care for a child who has been diagnosed with asthma. So it's important we understand how to provide really holistic care for these children, including preventing triggers. So not just knowing how to respond, but also how to prevent any asthma attacks or things that are going to trigger the child. We also need to know how to administer medication, follow medical care plans from the GP, which we will have a look at. Ensure a supportive partnership with the child's family. Now, we know all about the importance of working in partnership with families. So very important that we do that with medical conditions as well. And including regular and open communication. One of the things that we look at this evening is, in fact, a communication plan. So we look at how important it is that between medical professionals, us as the family daycare educator, and the family, we all have really open channels of communication. We'll have a quick look at what asthma is for those who are unsure. So the symptoms when children with asthma have inflamed or sensitive airways in their lungs, that is what we are looking at when we are talking about asthma. So when exposed to certain triggers, the airways react abnormally and they become very inflamed on the inside. So young children can experience a range of symptoms, including wheezing, which is very common, a persistent cough, shortness of breath, and very tight in the chest. So they're the most common symptoms that we see. Children will often communicate having a sore chest, or sometimes they get a bit confused and they say they have a sore tummy, but they're actually talking about their chest area when experiencing asthmatic symptoms. Now, to look at wheezing specifically, because it is so common, it's worth also mentioning wheezing and coughing can be very common in preschool age children, but it doesn't always indicate the presence of asthma. So if you do notice that a child is frequently wheezing, inform the parents of your concern and advise to get checked by a medical professional. So wheezing happens when the small airways in the lungs become narrow and tighten, and this is commonly caused by respiratory viruses or colds. So if you've had an illness this winter or a previous illness, you might be familiar when you've got viruses or colds, you can get similar symptoms, or it could be due to the weather. So common occurrences of wheezing in young children aged 0 to 5 can make asthma particularly difficult to diagnose. The lung function tests, also known as spirometry tests, they can't be performed on children until they're over 5 years. So it can be a little bit tricky to diagnose asthma in this age group that we look after, that 0 to 5 group. If children, 2/3 of children who have frequent wheezing don't necessarily develop asthma, and it usually can resolve, so that wheezing can resolve by the age of 6. So a great step that you can take as an educator, if you do have any concerns, is to keep a symptom record to share with the family. So you can record when the child presented with the symptoms, anything that helped them, what worsened it, maybe what triggered it. So looking at what the child was doing just before they began wheezing, because you might be able to find a pattern in triggers. And then that family can actually use that to inform the medical practitioner. So most children under 6 years of age will experience between 6 to 10 viral infections per year in their respiratory infection. So that's quite a lot, 6 to 10 a year. But they'll generally be quite well. So we know very well as family daycare educators that 0 to 5 group, sometimes, especially in winter, it can seem like it's one sickness after another, but it is quite normal. They're still developing their immune system. So those are just some things to be mindful of about wheezing. So here's a good visual that outlines the signs of an asthma flare-up. And we look at triggers. So there are many things that can trigger or worsen a child's asthma. And these include exercise, very similar for adults as well. Exercise, exposure to smoke or other pollutants, cold air. So many children develop a cough in the early morning or at night time. Illnesses such as colds, flus, viruses, pollen dust and other allergens, and emotions. So if children feel stressed or anxious or they're laughing a lot, you can often see that that triggers as well. So there's a few things of what we want to be looking out for. So their breathing, their speaking, what they look like. So if they look distressed and anxious, it could be because they're having trouble breathing. If they're pale and sweaty, bluish tinge to the lips showing a lack of oxygen, if they're drowsy or confused, and then that wheezing as well. So I want to take a closer look now at exercise-induced asthma, also known as EIA. Now, one of the most common triggers for asthma in young children is being active through exercise, sport, playing. We all know how active they are. So we know as educators that exercise and being active is a very important part of each child's daily routine for their health and well-being. So we therefore need to be aware how to manage EIA, exercise-induced asthma. When active, a child's rate of breathing increases and they'll often breathe through their mouth. So this can cause a lot of moisture from the airways, resulting in cool and dry air being inhaled. A loss of moisture, so cool and dry air being inhaled, and this can result in triggering symptoms. So to ensure all children are getting adequate exercise and are not excluded from physical activity, we can manage this because we don't want to remove them from physical activity. It's very important that they remain active. But we can manage it by conducting warm-ups and cool-down exercise, so before and after. We can check the child's medical management plan to see if there are any steps required prior to exercise. So their medical management plan might say, administer the reliever 5 to 10 minutes prior to commencing. We can ensure that a child's reliever medication is on hand and ready to use, so making sure that it's very accessible. Check air quality. So there's a good app that you can use, or there's a website as well, weatherzone.com.au/pollen. And this is a great site to check the air quality index. And then you can judge when it's best to go outside or when it's good to avoid outdoor exercise. If the rating is good or very good, then, you can do your outside activities. But if there's a really high pollen count and you've got quite a lot of asthmatic children, you could avoid going outside during those times. So a good little website to be aware of. Also avoiding windy conditions. Sometimes that can throw around the pollens and triggers a lot more. And avoid strenuous activities for any child experiencing a cold or flu. Now, if they are experiencing cold or flu, they should be at home. But if for whatever reason, maybe they're just recovering from an illness, just making sure they take it easy and then they're not straining themselves too much. So when we look at medications for asthma, there's currently no cure for asthma. We can't get rid of it altogether, but there are many effective medications available to support those who are diagnosed. So the aim of asthma management is to ensure that children can lead a healthy life while only taking as much medication as needed to keep them well, avoid any flare-ups, and participate in all daily activities. So it really comes back to making sure that they're being included. There are two key types of medication. So we look at relievers and preventers. So relievers relax the tight muscles around the airways. Reliever medication is provided when a child is experiencing asthma symptoms or an attack. So most children will have a blue-grey reliever puffer, which contains a medication called salbutamol. And this medication acts quickly to open the airways and only takes minutes to take effect. And it lasts approximately 4 hours. So it's used in asthma first aid. It relieves the symptoms. It relaxes the tight muscles. Easy to identify. It's usually in blue or blue-grey colours. Very quick to work, and it lasts for a few hours. And it's also used before exercise if exercise is a trigger. So if the child's triggered by exercise, as I said, their plan might say, take this 5 to 10 minutes before exercising. And sometimes it's used by asthmatic children, especially when they're unwell. So if they've got a bit of a viral illness. And then we look at preventers. So preventers prevent the inflammation of the lining inside the airways. Some children require preventers on a regular basis to ensure they control their asthma symptoms. Now, these can be used daily, even when the child is well, to prevent the onset of symptoms of a flare-up or an attack. So preventers may be prescribed during certain times, such as winter, when children are more likely to encounter triggers. So there's many kinds of preventers. They are often orange or red, but they can come in other colours. So this medication is it reduces the swelling in the lungs, making them less sensitive to triggers. Now, the most common method of administering inhaled medications is through a metered dose inhaler, an MDI. These are the most common used. These are commonly used with spacers. So I'm sure you've seen the spacers that you attach on. And sometimes for young children, you can also get the mask. So they put the mask on, then there's the spacer, and then there's the reliever or preventer. And that allows for the child to ensure that they're inhaling as much of the medication as possible. It's highly recommended that spacers are used by all children, as this will allow more medication to be delivered directly into their airways. So a spacer device helps children with asthma to use their puffer. And again, highly recommended so that we're getting that medication into the child's lungs. So here we have a bit of a diagram or instruction on how to use a spacer for children under 4. So we're going to remove the cap and shake the puffer, fit the puffer onto the end of the spacer, and then gently attach the face mask, putting that over the child's nose and mouth, making sure that there's no gap. So we want to make it nice and closed around the child's face, and then release the puff according to the medication plan and making sure the child's breathing in. And then for using a spacer for children over 4 years, so the only real difference is taking away the mask. So they're just breathing straight out of the spacer. And you can get pretty cool spacers now that make all kinds of whistle noises, so you can actually tell when the child is breathing in. And I think, yes, we've got a video here. So this is a bit of a demonstration of how to administer an inhaler. Now, when you're watching this, have a listen. I don't know if that's mum or an educator, but when she administers it, you can hear a little clicking sound, which tells us that that's when the child is inhaling, and we know that the medication's going in. So I'm just going to play this for you now. Okay, so as she was counting the breaths, it was just making that little ticking noise that was telling us that that medication has been inhaled. Now, it's also worth noting the side effects from asthma medication. So side effects experienced after the administration of relievers and preventers are uncommon. And if they do have them, they're very mild and they're not very dangerous. So some children may experience a bit of shakiness, hyperactivity, maybe sore throat or hoarse voice, bit of palpitations sometimes or headache, but the side effects tend to subside quickly. So a good idea is to always get children to rinse their mouth as well with water after taking the inhaler, just to remove any residue. But side effects are not something that we need to worry about too much. So here we have some asthma first aid for a flare-up. So first aid for an asthma flare-up or an asthma attack. Asthma flare-ups or attacks can occur quickly and develop over a few hours or even days. They can have a very slow onset. Now, signs of a flare-up include symptoms that are worse than usual, so symptoms that come back quickly. Even once you've administered first aid or administered medication, you find that those symptoms come back quite quickly, and that's when you know that you may be having an attack. It's important that in the case of a flare-up or an attack, first aid is administered immediately as things can worsen quickly. So we need to act fast. Educators should always follow the child's asthma action plan step by step. Action plans are discussed later in the booklet, so we will come back to them. And later in the session, and they're also in your booklet. So have a good look at the booklet that was sent out, and that will also be on the website. If the child does not have an individual action plan, you can follow the nationally recognised asthma first aid procedure. So that's the one there on the left-hand side, and there's also a simplified version on the right. But that asthma first aid, that's for the blue-grey reliever. So those the ones that we were looking at, the inhalers on the other screen, and those 4 steps are very much universal for if you don't have an individual plan for a child. So if unsure, always call 000 and ask for an ambulance. Better to be safe than sorry, because as I mentioned, things can escalate quickly, and what sometimes seems like something mild can get very serious. The educators should notify the family as soon as possible, and the general first aid steps for an asthma flare-up include: we're going to sit the child upright, make sure that we stay calm, because the worst thing we want to do is induce panic and get them more worked up. So stay calm, reassure the child, don't leave them alone. Give them 4 puffs of reliever inhaler using a spacer or a mask if that's necessary, and then 4 breaths between each puff. Wait 4 minutes, and if the child still cannot breathe normally, we're going to give 4 more. So 4 puffs with 4 breaths in between and waiting 4 minutes, and then repeat the process. If the child still cannot breathe normally, we're going to call an ambulance, immediately dialing 000 and informing the operator that a child may be having an asthma attack. And we're going to keep repeating step 2, so the 4 separate puffs of the reliever. We're going to keep repeating step 2 until the ambulance arrives. So a general asthma first aid plan, as seen on the slide, provides a first aid response to an asthma attack. And you can access this poster from Asthma Australia, and it follows the nationally recognised asthma first aid procedure by the National Asthma Council Australia. So a really good poster to print off and just have available, because unfortunately, a child might have their first attack in your service. So this is a good plan to follow for any children that don't have their own individualised plan. And then here we have an example. It hasn't been filled in, but this is an example of an individual plan. So this is unique to each child and is provided by the parent or carer at the time of enrolment or at the time once they're diagnosed. So these plans detail clear instructions, when and how to administer medications, and what to do if symptoms worsen. So these plans are completed by a medical professional, so a GP or a practitioner, and they should be reviewed every 6 months or so to make sure that they're current. So making sure if you do have any children that are enrolled that has this plan, we must follow that. And so it takes you through the steps. There's different ratings there. So what to do if the asthma is well controlled, what to do in the case of a flare-up, what to do if it's severe, and then what to do if there's an emergency. So how to support a child to understand their condition. Now, this is a really important thing for us to look at tonight. We talk a lot about first aid and what educators need to do and how we can manage these medical conditions, but really important that we take time to think about what the child's thinking. So another great way we can support children with asthma is to help them understand their condition and give them confidence in how to manage it. You can simplify the condition by explaining it in a way that they understand, or you can use visual diagrams that are age appropriate, whatever you think is going to support the child. So below there's a great script that you can use for young children to explain asthma, sourced from Asthma Australia. So we can explain to children, you have 2 lungs in your chest that are filled with lots of airways. And the lungs' job is to move air around our body so that we can breathe. But people with asthma have sensitive airways that can get very tight and swollen, and this can make it hard to breathe. So you might cough, or you might make a whistling sound with your chest. And this means that your lungs are unhappy. So when your lungs and airways get unhappy, it can cause you to cough, or you might feel very tight in your chest, and it can be a bit scary. And that's why we need to have medicine. And you could show them a bit of a picture like the one on the slide there of what happens when they are finding it hard to breathe, and reassure them that the doctor and their family and you as their educator, you're all there to help them and you will look after them. So sometimes we forget that it can be very scary for the child involved. Okay, so we are now going to play our video. And this is our interview with Kathryn Mulligan, who is from New South Wales Anaphylaxis Education. And she is being interviewed, and she's going to give us some really great insight into the management of anaphylaxis. And then we will go into our second part of our session, looking all about anaphylaxis and allergies. And then we will go into looking at some documentation. So I hope you enjoy the interview.
Hi, everyone, and thank you for joining us. I'm pleased to introduce Kathryn Mulligan. Kathryn is a clinical nurse specialist for New South Wales Anaphylaxis Education, who is here today to share her knowledge and some strategies in managing anaphylaxis in family daycare services. A very warm welcome and thank you for joining us today, Kath.
Thank you for having me.
My name is Rachel and I'm joining you from Gadigal country. Can I ask where you're joining us from today?
I have the pleasure of joining you from Durham country.
Wonderful. So, Kath, to start off, do we know why some children develop allergies? And do you think we're seeing an increase in diagnosis?
So there is definitely an increase in allergies. It's not a case of they've been around all the time and it's just that we're seeing it more. There is actually definitely an increase in the incidence, and it's increased since probably the late 90s. So we know that about 1 in 10 one-year-olds has diagnosed food allergy. So that's 10% of one-year-olds. It's quite a big jump. And we know that drops to about 1 in 20, I was going to say food-age children. No, that's not right. School-age children. So it is definitely a big increase. The reasons are many, so it's multifactorial reasons. It has a lot to do with the environment. There is a genetic component to it, so but it's mainly the environment. So we know that so people that live in cities are more predisposed to developing allergies than people that live in the country. We know that there is a genetic component. We know that there are children from who are first generation Australians who have particularly parents who are from an Asian background. They are much more likely to develop allergic diseases than children who are not. And we know that there's a lifestyle component. So there's dietary component to it. There's also things like vitamin D, exposure to animals. There's all sorts of kind of factors that play into the development of allergies. There's lots of research going into why. Unfortunately, there's not one answer to that question.
Yeah, surprising how many factors are involved in that.
Yeah, it would be nice if we had one reason that we could change. Yeah. One reason that's causing it, one reason we could change. Unfortunately, it's not that simple.
Having a child going to anaphylactic shock can be a scary situation for all involved. In your expert opinion, what are some strategies our lovely family daycare educators can do to minimize those risks for children with anaphylaxis?
So I think it's really important to be informed. So what I would suggest is that you get as much information as you can from the family. So get information about the child's condition, so what allergies they actually have, and what paperwork you can get. So things like the Asthma action plan, and talk to the families, because remember that the families are, the parents, the carers are experts in risk managing that child. They do it every day. Every time they step out of the family home, they are managing risk. And there are lots of good resources out there. So one of the best resources I would encourage you to go and have a look at is the best practice guidelines. There is a section there for the early childhood sector, and there's some great resources there. There's things like risk management examples. There's just general information. There's policy documents which might not help you, particularly in family daycare, but it's still informative. There's also some food allergy training, online training that you can do if you feed children in your environment, in your service, or if you actually handle food, which is pretty much everybody. So that's really helpful as well. And it's important that you know the differences between things like food allergy and food intolerance. So I know there's lots of confusion out there for children who have milk allergy versus milk intolerance or dairy intolerance. So make sure you know the differences, because that's where a lot of mistakes are occurring. For instance, people might think that you can give someone with a milk allergy lactose-free milk, and that's not actually the case. There's confusion about gluten intolerance versus wheat allergy. Make sure you're informed, and if you don't know, you can always contact us here at the New South Wales Anaphylaxis Education Program. The most at-risk time for mistakes to occur or for incidents to occur is obviously around food. So that's where the risk management strategies need to be the tightest. So supervision is obviously really important. Checking to make sure that children are actually eating from their own lunchbox. That's a really important thing. So checking that the right child is eating from the right lunchbox, making sure that their items are labelled, and especially things that move around, which tends to be things like drink bottles, that it's labelled, and that children are actually drinking from their own drink bottles, because when drink bottles are shared, whether knowingly or unknowingly, that's where there can be some cross-contamination, and children can actually have reactions from that. Hand washing before and after eating with soap and water, really, really important risk management strategy. So that can stop messy eaters taking food allergens from one area, from their eating area, into other areas like play areas. And that's important for stopping the spread of food allergens. Looking at the activities that you're doing with the children. So craft activities are a good example. Looking at what you're using in craft activities. If you're going to be playing with Play-Doh, Play-Doh is made with wheat flour. So if you have a wheat allergic child, you can't use Play-Doh. You might have to make the gluten-free. It's not as great, but the gluten-free Play-Doh, so that that everyone can still have that hands-on experience and learn all those great skills that they learn from playing with Play-Doh, but nobody's put at risk. If you're going to do threading with pasta, for instance, if you have a wheat or an egg allergic child, you might need to use rice pasta instead. So there's lots of substitutions that you can use so that you still get to do that experience with the child and do that activity, but nobody's health is at risk. Egg cartons shouldn't be used for a child with an egg allergy. You might have to either buy them that haven't had egg in them or just use something else. Milk cartons shouldn't be used if there's a dairy allergic child, things like that. So there's lots of risk management strategies that you can put in place, and I'd again encourage you to go and look at the best practice guidelines, because there are lots of examples. There's actually a PDF risk management examples document there. And once again, if you're stuck, please contact us here at the New South Wales Anaphylaxis Education Program.
That's excellent. That was a really comprehensive list of strategies. So that's awesome. Lots of things you don't consider, such as food as play, being those triggers as well. So thank you for that. Now, a lot of our family daycare educators watching tonight may feel quite anxious if they had to administer an adrenaline injector. What are some ways to alleviate this anxiety in an emergency?
I think absolutely the most important thing is to have really good training. Good training can increase your confidence and increase your competence. If your training that you've had up to this point has not focused on the ASCII action plan and knowing how to read and follow an ASCII action plan, then your training's not okay, and you need to look at getting different training. So knowing how to read the ASCII action plan can really change the game. It means that you can look at a child having an allergic reaction, and the ASCII action plan tells you when and how to deal with an allergic reaction, and when and how to give an adrenaline injector. That's a game changer. And you shouldn't be dealing with an allergic reaction without following an ASCII action plan. So that's absolutely my number one tip. Other things that can kind of alleviate some of those stresses is knowing that adrenaline, which is what is inside an adrenaline injector, the EpiPen or the Anapen, is not dangerous. I have quite a bit of adrenaline running through my body right now because I'm being recorded. I'm being interviewed. It's a little bit nerve-wracking. So when our bodies are under a bit of stress, our bodies release adrenaline. We make it in our own bodies. Our brain releases it. It's part of the fight, flight, or freeze response. And that can give you a bit of comfort because it's not dangerous. Our bodies are used to dealing with it. So in terms of giving it to a child having anaphylaxis, you're not going to do them any harm. It's just adrenaline. People jump out of planes for a dose of adrenaline. People drive fast cars for adrenaline. It's only adrenaline. I've seen it work many, many times. Well, I can't even tell you how many times I've seen adrenaline work, and it is awe-inspiring. When you see a child that's really, really unwell, they're having problems breathing, they feel they can't take a deep breath, they're coughing, they're wheezing, their blood pressure's in their boots, and they get a dose of adrenaline, and you just start to see those symptoms dissipate. It is absolute magic. And I can't stress to you how important it is that you give adrenaline if the child needs it. So you've really got to understand that adrenaline is not dangerous. If a child needs adrenaline, you need to give adrenaline. So you need to give the EpiPen or the Anapen. You can't overdose a child by giving an EpiPen Junior or an EpiPen, whichever they have prescribed, or whichever one you have as a first aid device. And as long as you follow an ASCII action plan, you're going to be doing the right thing at the right time. The other important thing to know is on each of the ASCII action plans that you come across, there is a line on the action plan that says, if in doubt, give the auto-injector. And that line means that we as a health professional community are confident enough that if you are unsure if the child's having a mild to moderate allergic reaction, or if they're having anaphylaxis, or if you're not sure if it's asthma or if it's anaphylaxis, we're okay for you to give the adrenaline injector because you're not going to do them any harm. Adrenaline is not going to kill them if they're not having anaphylaxis. It'll wear off in 20 minutes, no harm done. Adrenaline opens airways, it makes the heart contract harder and stronger and more efficiently, it increases blood pressure. It's awesome, and it's not dangerous. And if that's all you can get from my answer, then I've done my job. And the flip side of that is if you umming and ahhing going, I don't want to do this, I don't want to do this, I don't want to give the child the EpiPen, that can be dangerous. If a child needs adrenaline and you don't give it, that's when the child can get really, really sick and we can have really bad outcomes. Yes, it comes in the form of a needle. An EpiPen or an Anapen contains a needle that goes in the outer mid-thigh. it hurts for about 2.5 seconds, 3 seconds, and then it's over, and the child will feel better. And that's what we have to focus on, is that it is going to make them feel better.
So, Kath, you've spoken about the importance of action plans a few times tonight, and we're also aware that ASIA are introducing an updated action plan from mid-May 2023. Why has the action plan changed?
So since the Anapen has been introduced, we've now got 2 adrenaline injectors in Australia, which is a great thing. It means we've got the option of the EpiPen and the Anapen. In the past, we've had a few shortages of the EpiPen. The most recent one occurred in March. The EpiPen Junior, there was a shortage of that device, and that is really stressful. In March, when there was a shortage of the EpiPen Junior, it was great because we had the option of there being an Anapen available, an Anapen Junior. The problem with that and the current action plan with only one device instructions on it was that we had people who were being able to get an Anapen Junior, but the action plan was for an EpiPen. So the device and the action plan didn't marry up. So that caused both logistical problems for, childcare who had an Anapen Junior and an EpiPen kind of mismatch. But also, if you're in a situation where you have a child having anaphylaxis, you want to have the device and you want to have instructions for use that match. Because you don't want to be in a situation where you don't know how to use this device that's in your hand and you don't have the instructions to tell you how to use it. So ASCIA have decided that the way around this and the way to make it easier is to develop an ASCIA action plan that has the instructions for both the Anapen and the EpiPen on the same action plan. So that's going to streamline a lot of things. The other thing about the changes is that pharmacies can, if a doctor prescribes an adrenaline injector, either adrenaline injector, pharmacies are able to dispense the other adrenaline injector if a little box on the prescription's not ticked. So if, for instance, a doctor writes an EpiPen script, they can actually dispense an Anapen, just like if you go into a pharmacy and you have most prescriptions, that you can be offered a cheaper option of that medication. That's pretty standard. So it allows that to happen. So the changes in the action plan mean that there's going to be less logistical problems with the device and the action plan not matching. That's the main reason.
Well, thank you so much for joining us today, Kathryn. That was really informative. Our participants will gain a lot of insight and tools to help them on their journey to safely managing anaphylaxis.
Thank you for having me.
Hey, what a great interview. I hope you learned lots of information. I certainly really found it beneficial hearing about how adrenaline isn't risky. It can often be really daunting or overwhelming, the thought of administering an EpiPen or an Anapen. So really great to hear that it's not that high risk thing that we may have all been quite anxious about, that we're not going to hurt the child by administering that. So really good points. We really appreciate that interview. So this is a great time to go into the second part of our presentation for this evening, all about anaphylaxis and allergies. So what is anaphylaxis management and why is it so important? So in Australia, food allergy is estimated to affect 4 to 8% of children under 5 years of age, so quite significant numbers. Recent Australian data indicates that 10% of children aged under 1 have a diagnosed food allergy, so 10% of children under 1 year of age. Many food allergies in children are not severe and will disappear with time. So the most common triggers of allergic reactions in children are eggs, peanuts, tree nuts, and cow milk. Other less common but still major food allergies in Australia include sesame, soy, and wheat. So peanut, tree nut, sesame, and seafood allergies are usually lifelong. They're the ones that tend to stay with children beyond their childhood. Children often outgrow cow's milk, eggs, and soy and wheat allergies at some point throughout their childhood, but a minority of people have these allergies into adulthood. Now, anaphylaxis is the most severe form of allergic reaction. So allergic reactions are on a spectrum. So you can have a mild to moderate allergic reaction, or you can have a really severe allergic reaction. And a severe allergic reaction is called anaphylaxis. So anaphylaxis is just sitting very high on the spectrum of allergic reactions. Key principles for family daycare educators to be aware of when managing anaphylaxis in care. So the first one is creating risk management plans, which we will look at later this evening, individual care plans and communication plans for any child with an allergy. Ensuring that a child's action plan and adrenaline injectors are stored together in a safe location. So you want their plan and their medication together. Children need to always have their prescribed medication and action plans with them. Ensure that your training is up to date. And we heard about this in the interview. Very important that your first aid training includes asthma and anaphylaxis management. So you should feel confident in how to respond to an emergency and administering medications. Now, the current first aid unit, the HLT Aid 012, which sits inside the Certificate 3, is specifically for early childhood educators. So it's designed for educators looking after children in that 0 to 5 group, and it does include asthma and anaphylaxis training. Be aware and prepared for unexpected allergic reactions in undiagnosed children. So it's recommended that all family daycare educators purchase an adrenaline injector for general use. And we're going to talk about general use injectors shortly. So that's an auto injector, so an EpiPen or an AnaPen that hasn't been prescribed to a child. It belongs to the service or the educator and stays in their home in case that a child has their first reaction in your home. We don't want to be using someone else's pen if we don't have to. So it's like a pen for your service. Implement risk management strategies to reduce allergic triggers occurring. So we often see services that say that they're nut-free or egg-free, or they avoid things. We heard in the interview about avoiding things like craft materials, egg cartons if you've got a child with an egg allergy. Having clear medical conditions policy. And I know that a lot of you said that you've reviewed yours in the last 12 months, which is fantastic. But if you haven't, making sure that you go through that policy and you're familiar with it. Provide age-appropriate education for children in your care around different medical conditions. So educate them on how, if age-appropriate, how they can look after themselves, and also look out for their peers. So being mindful of their friends who have allergies or medical conditions so that they can also care for them. Ensure appropriate reporting after an incident, so document reflection post-event. If you need to have counselling after a traumatic medical episode at your service, that's something else you can seek. But really engaging in some critical reflection if you did have a medical emergency about how it was handled and if there's anything you could potentially do better. Communicate anaphylaxis management with the community to heighten awareness and understanding. As family daycare educators, we can really advocate for those diagnosed with anaphylaxis and create a more aware and thoughtful community. Let's have a look at those principles bit closer now. So risk management strategies for anaphylaxis. This is how we avoid or reduce the risk in the environment. So Allergy and Anaphylaxis Australia, the National Allergy Strategy and Australasian Society of Clinical Immunology and Allergy developed a great document called Anaphylaxis Risk Minimisation Strategy for Schools to guide all early childhood services to reduce exposure to any known allergens of children in care. So these strategies can be implemented by the family daycare educator, but should always be done in consultation with parents or guardians and remain relevant to each child's individual anaphylaxis care plan. So there are 6 key areas we need to focus on when minimising risk. The first one is, and these were touched on in the interview as well, the first one is food from home. So clearly label lunch boxes. The last thing we want to do is for children to accidentally access someone else's lunchbox. Water bottles and baby bottles, very important because milk allergies do exist. If a service does not provide meals and parents are providing food from home, it's reasonable for the service to request the food provided by parents does not contain peanuts or tree nuts. If a child has a really complex allergy, only consume food brought from home rather than provided by the family daycare educator. Meals and mealtime supervision. Now, this is probably one of the the most important ones is supervision. So it's recommended that we obviously monitor meal times very closely. So that means sitting with the children, maybe even sitting close to the child with the allergy or the medical condition. You could even serve a child with an allergy on labelled plates and bowls, cups that are just for that child and that they're easily recognised. We don't want to isolate children from meal time. So, making a child that's anaphylaxis sit away from the main group. It's all about still being inclusive. So the way we can do that is just increasing our supervision and being with them. You could consider having separate high chair for a child with an allergy that only they use. The other thing we look at is indoor activities. So games, crafts, activities shouldn't involve allergen food. This is where they were talking about recycled craft materials, making sure that we're aware. Even face paints, they can sometimes contain allergens. Play-Doh was mentioned. So obviously with wheat-based flour, being mindful of that. And then when we look at outdoor activities, so cover bins so that they don't attract insects, being aware of bees, if they can also cause an allergic reaction in some children. So being aware if you've got lots of flowering plants in the garden that you may be attracting bees. Also any domestic animals, being mindful of allergens there, or any edible things in the garden, fruits, herbs, vegetables that may cause an issue. Something else that we need to do risk management for is special events. And I'm sure we've all had an occasion, maybe a birthday or a Christmas function or something in the home. We don't want children to miss out on these special fun events, but we do need to be aware of allergies and we might need to do things slightly differently. So it might come down to educating the other parents in your service or the other carers, making them mindful that we do have a child with allergies and they need to be provided for as well. So family daycare educators need to be aware of what's consumed in their home, what's in your personal kitchen or your personal fridge if you're sharing a fridge with the family daycare environment. Do we store food from our service separately from our home foods? And are our family members aware of bringing allergens in? So family daycare educators just have a little bit more, of an element that they need to look at because they are in their home environment. And then lastly, medications, creams, and latex. So any medication administered in the service should be given in accordance with the policy. Being mindful, some soaps or nappy creams, moisturizers, even sunscreens can contain ingredients. Sunscreens can contain food products such as nut oils or goat's milk. Latex gloves can be an issue. So just being really mindful of what's in your first aid kit and what is in any medical or creams, things like that. So it's imperative that as family daycare educators, we know how to recognise an allergic reaction. So the mild to moderate symptoms include swelling of the lips, tingling mouth, hives, abdominal pain. So the first time a child has any allergic reaction, they need to go to a doctor, and they will confirm if the child has an allergic reaction and advise how to treat in case of future events. So they may be referred to an allergy specialist. So just being aware, occasionally a more severe reaction can occur, and this is where we look at severe allergic reactions, which is our anaphylaxis. So you can see on the slide there, signs of anaphylaxis. They can have difficulty breathing, swelling of the tongue, tightness of the throat, wheezing or persistent cough. So some of those ones are quite similar to the symptoms we looked at in an asthma attack. So if you've got a child who's asthmatic and they're having an anaphylactic reaction, it can be quite a challenge to be able to tell the difference. They can have difficulty talking, they might become dizzy, pale and floppy for really young children, and abdominal pain and potentially vomiting. The abdominal pain and vomiting is more common in insect allergy anaphylaxis. So how are we going to respond in an emergency to an anaphylaxis reaction? So if a child is showing the signs and symptoms of anaphylaxis, we need to immediately administer adrenaline injector. Now that is something that we heard in our interview just now, that better to be safe than sorry, and there should be no fear around administering adrenaline. It's much better that the child receives that because they can be very unwell, and it can have fatal consequences if they're not administered adrenaline, if that's what they need. So following the child's ASCIA action plan, this document clearly lays out the signs to watch for and what to do, making sure we have a mobile phone readily available so that an ambulance can be called, ensure the parent of the child is notified as soon as possible. After an adrenaline injector has been administered, the child should stay in position as per the plan and transported to hospital by ambulance for medical monitoring for at least 4 hours. So do not allow the child to stand or walk around. Even if they appear well, they need to stay lying flat. Lie flat or sit with the legs outstretched. After adrenaline injector has been administered, an ambulance must be contacted for medical monitoring. Ensure the family replaces, now this is a very good point, ensure the family replaces the injector before their next attendance at your service. You do not want a child with anaphylaxis present at your service without their required medication. Very important. It's also a good idea for family daycare educators to conduct an anaphylaxis drill. So just like we do our fire drills or our lockdown drills, really good idea to do an anaphylaxis emergency drill. Exactly what is it that you're going to do as an educator? It can be a very stressful situation because you're still responsible for the care of the other children. So thinking exactly, if I had a child have a reaction right now, what am I going to do? And just practicing walking through the steps, being aware. We always want to follow the ASCIA action plan in case of an allergic or anaphylaxis reaction. If the child's having a reaction and we don't know of any allergy, so they may not be diagnosed, they won't have an EpiPen, they won't have an ASCIA action plan, then we can follow the first aid action plan for anaphylaxis. So this is the general first aid administration. And these images are from allergy.org.au. So we're going to hold the EpiPen with the orange tip. Now this is for, what's our first one? This is for Anapen. So we're pulling off the needle shield. We're pulling off the grey safety cap from the red button. We're going to place it firmly against the outer mid-thigh at 90 degrees. And it doesn't matter if the child still has their clothing on, it will go through the clothing. Press the red button so it clicks and hold for 10 seconds and then remove. And then with an EpiPen, quite similar, we're going to form a fist around the EpiPen, pull off the blue safety release. So unlike the Anapen, our thumb's not on the top. We're just creating a fist around the pen. Hold legs still and place the orange end against the outer mid-thigh, with or without clothing, again, doesn't matter. Push down hard until you hear a click, and that one needs to be held for 3 seconds. So you can imagine in a very stressful situation, you know, we need to be aware of those steps. So if you can do a bit of a drill every now and again, even practicing with a permanent marker, and just being aware of what to do. Now, educators should be reminded that, as stated in Regulation 94, they do not need parental consent to give adrenaline in an emergency. Even if the child doesn't have an action plan or an EpiPen, they could be having their first anaphylaxis reaction, in which case we really want to administer that adrenaline to help save the child. So you are not looking at getting parental consent here. If it is done in the case of an emergency, if it's high risk, you can do it without. So let's have a look at the ASCIA action plan. So there's also a series of green action plans. Now these are for allergic responses, the green ones. So you can go onto the ASCIA website and have a look, or you may have already seen them. But I haven't put them in the slide tonight because I didn't want to confuse you with too many plans. So this one, we're just looking at the anaphylaxis. So this plan is the updated one. So they have recently updated the layout of these plans, and I believe they were going to be published in May, so they may already be out, but just being mindful that they were amended slightly. So if you're thinking it looks different to the ones that you have, they were only very recently updated. So just keep an eye out for those updates. So you can see it has the instructions on the side there for EpiPen and Anapen, the steps, and there's also a space up the top for all the child's details. And also the emergency contacts and the child's photo. So this new one that was developed by ASCIA in 2023, which, as I said, they were due to become available from mid-May, so they are possibly already out. This is the first major formatting change in 20 years. So this is the first time they've updated this document in 20 years. It was first introduced in 2003. So only now in 2023 are we seeing these updates. And this slide here shows you what was updated with the form. So patient-specific details are completed in this top section. There's now the signs of and actions for mild to moderate allergic reaction with a very easy to follow list. Signs of and actions for anaphylaxis is unchanged. Wording about allergen exposure is included in this section. Introduction, there's instructions for adrenaline injectors, and they're color coded for the 2 different brands, so Anapen and EpiPen. So a few changes there. So it does look similar, but they've obviously just made a few improvements. Now, a common question around adrenaline injectors is, should services have an adrenaline injector available as part of their first aid kit? So this is where we're going to have a look at general use adrenaline injectors, which I spoke about. The National Early Childhood Law does not require services to have a general use adrenaline injector. However, the National Allergy Council Best Practice Guidelines recommends that all early childhood services, including family daycare educators, consider purchasing an adrenaline injector for general use. So whether that's an EpiPen or an AnaPen. And this should be kept in an easily accessible, unlocked location with an Askia first aid plan. So you're not going to have an individual Askia plan because it's not prescribed to any child in your care. This is a general use pen that becomes part of your first aid kit in case a child has their first reaction at your service. Now, we want it out of reach of children, of course, but we want it easily acceptable. It's now recommended that you don't keep these kinds of things in locked cupboards. Medication should be easily accessible by educators. So this adrenaline injector, a general use one, could be used in circumstances such as a child who is known to be at risk of anaphylaxis does not have their own device immediately accessible, or maybe their device has passed its expiry date. So you might have a child with their own EpiPen, but for whatever reason you can't access it, or it's expired. Sometimes as well, a second dose of adrenaline is required before the ambulance has arrived. So sometimes the ambulance might instruct you to administer a second dose of adrenaline. This is where you could use your general use pen. Also, a child's device has misfired or accidentally been discharged, and it does happen in these emergency situations. You've accidentally released it, or something's happened, or maybe it's a faulty pen. You could use your general use pen. And again, a child has their first anaphylaxis reaction in your service. They don't have a pen, they don't have a plan. You can use your general use pen. So having an adrenaline injector for general use should be considered as being additional to the prescribed adrenaline injectors and should not be a substitute for children having their own pen. So if you do have a child that is diagnosed, they must have their own prescribed adrenaline injector. We're not trying to replace that. This is just for other situations. And then making sure you have a copy of the Askia first aid plan to use with that pen. Make sure your general use injector is appropriate for the age of the children. So we'd be looking at EpiPen Junior as pictured there, or AnaPen Junior. Another common question often asked is, can an educator use another child's prescribed adrenaline injector if there is no other option? So the best practice guidelines document states if another child's adrenaline injector is used in an anaphylaxis emergency when there is no general use adrenaline injector, it's essential that that child's parent is notified and the device is replaced immediately by the service. The child whose injector has been used would also now be at risk with no prescribed medication. So this would need to be managed. Adrenaline injectors are available from pharmacies without a prescription. So you could go in tomorrow to your chemist, and as long as they have them in stock, you could access one. So that's just clarifying that, say you had child A, they've had their first peanut allergy, anaphylaxis reaction at your service, but they haven't been diagnosed before and they don't have an EpiPen. But you have another child that has an EpiPen. So you've got no other option. So you're going to use child B's pen on child A. But something to be very mindful of is that now child B it's very likely that they could become exposed to the same peanut allergen. If something's in your service, maybe someone's accidentally brought in a peanut butter sandwich, it could just be a matter of time before they're then exposed. You have to manage that very carefully. You've now given another child's medication to a child, which is fine because it was an emergency response, but you now have another child that's very vulnerable. So it is up to the service to replace the pen in that situation, and you will be sending that child home until they can get replacement medication. Okay, so we also look at, and we touched on this in our asthma section, educating and empowering children. So as discussed with asthma management, we can also use our role as family daycare educators to help children learn how to manage and be aware of their own allergy and look after their friends with allergies. So we can educate preschool age children to be allergy aware and take simple steps like washing hands before and after meals, not sharing food, and speaking up if they're feeling unwell. And this is really good preparation for big school, being mindful of their friends. Our educational program is a great opportunity to address any dietary requirements or allergies in the service. We can also use role play or puppets and storyboards to create scenarios. So peer education about the seriousness of food allergies can help educate children and prevent food allergy specific bullying. So it does happen. Children can get picked on and bullied because of their allergies or because of their medical conditions. So we can teach children to help alert us if they notice that their friend is not well. Very important when they're in big school and the supervision is not nearly what it is in early childhood. If they notice that their friend's starting to show symptoms of not being well, they can play a really important part by advising an educator. There's also some great resources available on the Allergy Anaphylaxis Australia website. There's the Be a Mate poster, which is that one there, how to help keep schoolmates with food allergies safe. So nice diagrams there. There's Jeremy's Cake. So Jeremy the Wallaby, this is a storybook. Jeremy the Wallaby has a life-threatening allergy to egg and nuts. And he also has hay fever and asthma. Poor Jeremy. He lives in a rocky outcrop near a billabong with his mum and dad, and his friends Bruno the kangaroo, Tam and the bilby, and Edward the wombat. So it's using Australian animals and the situation of a birthday on how to keep friends safe. And then there's also Tommy's Big Birthday, which is by the Wiggles. So for it's aimed at 3 to 8 year olds, and it tells the story again of someone going to a birthday party. Tommy has egg and milk allergies, and it just shows that you can still have fun at parties, even if you've got allergies, but you just have to do things a little bit differently and keep safe. So there's some great resources there. So how to store adrenaline injectors. So you can see on the slide there, adrenaline injectors are exempt from being stored in a locked first aid cabinet. They should be kept in an unlocked central location with the child's name or labeled general use if it's for first aid. So you would just have a big clear sticker saying general use. They must be easily accessible in an emergency, but out of reach of children. So adrenaline injectors, very important. They must be easily accessible and store at room temperature. So we don't want to store them in the fridge, away from direct sunlight. Ensure a process is in place to regularly check expiry dates of all injectors at your service. So doesn't matter how you do it, making sure that you've got the expiry dates recorded somewhere so you can easily keep an eye on that. Families may be unable to leave an adrenaline injector at your service. So sometimes they may have to take it home with them every evening if they're unable to have one in each location. Therefore, there should be a procedure in place to make sure that it's handed over every morning with the child and returned every evening. So how that looks is really up to you, but making sure that it's done effectively. Should a situation arise where only an expired adrenaline injector is available, then this should be used rather than no device at all. So better to use an expired device than no device. If taking adrenaline injectors off-site for an excursion or regular transport, don't leave them in the car or the bus because they can overheat. So we want to take it with us. Now, the following are some points that need to be collected by educators for all anaphylaxis reaction. So if a child has an anaphylactic reaction in your service, this is all the information that is required to be collected. So you would record the child's name and date of birth, the date and time of the allergic reaction. You'd be recording if they already have an Asthma action plan. What caused the allergic reaction? So what was the child exposed to? How did the exposure occur? Was something accidentally brought into the service, or did they accidentally eat someone else's food? If there are no known allergies, then what was the suspected cause? So if you think something may have triggered it. Your name and position, any signs and symptoms observed. Was the child's Asthma action plan followed? Where was the allergic reaction when it occurred? Where was the child treated? Was the child positioned appropriately? So sitting with their legs outstretched or lying down. Was there an adrenaline injector? And if not, why? Was it expired or misfired? Keeping in mind that if we've only got an expired pen, if that's our only option, then we're going to use it. And then more information about what medications were given, including any second dose of adrenaline. When was the ambulance called? And details about the hospital that they were transported to. So there's a lot of information that needs to be recorded. Now, before we finish up anaphylaxis and go into our last part of our session tonight, which will be all about documentation, I just want to refer you to this great document. It's the best practice guidelines for anaphylaxis prevention and management in children's education and care. It's based on current evidence base and best practice. So the guidelines have been developed in consultation with key stakeholder organisations, staff working in early childhood, and parents of children who are enrolled in services. So it's got a really great collection of different perspectives, medical, educators, families. These guidelines aim to provide best practice guidance and associated support documents to reduce the risk of anaphylaxis in services while supporting children to participate in the full range of activities. So you can scan the QR on your code there. And download that document. Otherwise, if you want to do a Google later, if you're listening to this on podcast, it's the best practice guidelines for anaphylaxis prevention and management in children's education and care services. It's a really good document there. It's quite a big one, but it's good. Okay, the last thing we're going to look at now is general information for both asthma and anaphylaxis in family daycare, including looking at the documentation that we need to do. So on the next two slides is a table of some of the key legislative requirements for medical conditions. So here we're really looking at compliance. And when dealing with medical conditions in children, there's an extensive list of legislative requirements that family daycare educators and services must adhere to. But these requirements also set the foundation for our policies and procedures to keep children safe. So anything like this, especially really important things like medical conditions, we're always making sure we refer back to policies and procedures. And we know that they stem from the compliance in our regulations and laws. Now, not to scare you with the next slide, but this is the long list of regulations that relate to medical conditions. So we have the Act 167, which is all about offences relating to protection of children from harm and hazard. And essentially that's what this is all about, isn't it? We really want to keep children safe from harm and hazard, whether that's asthma, anaphylaxis, allergies. And then there's lots of other regulations there, and you might like to visit these in your own time and have a look. We have things like Regulation 85, which is all about incident, injury, trauma and illness policies and procedures. And we know that there's a lot of documentation around that in our services. Regulation 86 is about notifying a parent of any incident or injury or illness. Records that need to be kept, Regulation 89, first aid kits, Regulation 90, the need to have a medical conditions policy, very important. So Regulation 90 outlines the practices that the service's medical conditions policy must set out, including the requirements of a parent to provide a medical management plan for their child, requiring the development of a communication plan. So very specific information there. So I really recommend that you have a look closely at Regulation 90. Regulation 91 is ensuring that if a child enrolled at the service has a specific healthcare need, allergy or other medical condition, that the parent of the child must be provided with a copy of the medical conditions policy. So keeping in mind that you are providing that policy to those families. Regulation 93, administration of medication, again, very important, and there's a lot of information in that regulation. We must have written authorization from the parent or guardian, unless, of course, as we mentioned before, it was an emergency response. If the prescribed medication is in its original packaging with the child's name and dosage, the medication must have the original packaging with the name, the dosage, expiry date for us to be able to accept it. Regulation 94 is that one about exemption to authorization. So that's in an anaphylaxis or asthma emergency. You do not need to get permission to administer medication if it's life-threatening. So you can have a look at that in Regulation 94. And Regulation 136, all about first aid qualifications. That's for staff as well, for educators, very important. Then we've got Regulation 162, health information to be kept in enrolment forms. So Regulation 162 is a good one to see what exactly you need to get from families when they are enrolling. So specific healthcare needs, allergies, including if the child's been diagnosed. So you must ask that question at the time of enrolment. Regulation 168, education and care services must have policies and procedures, which we know. And then Regulation 169, additional policies and procedures for family daycare. So making sure you're very aware of that one. And then following on, we've got 170 to 173. Again, more information required about policies and procedures. They need to be followed. They need to be kept available. Families need to be notified if there's any changes to policies and procedures. And the prescribed information that needs to be displayed. So point 2 here, in the case of a family daycare residence or approved family daycare venue, a notice stating that a child who has been diagnosed as at risk of anaphylaxis is enrolled in the family daycare service and attends the family daycare service or family daycare venue. So you must have a sign or prescribed information available that you do have a child that has been diagnosed. So very important. So that's a good list of regulations to, if you want to check up on your compliance. And then it's good that we have an understanding of what do the national quality standards say. So below are the key elements from the NQS that we look at. So a lot around quality area 2, 2.1.3, effective illness and injury management and hygiene processes. Quality area 6, we're looking at effective partnership for children to participate in the program. And quality area 7, systems are in place to manage risk and enable the effective management of quality of service. Very important. So reflective questions from the guide to the NQS for family daycare educators specifically. How do family daycare educators and coordinators discuss and manage risks associated with working in isolation when managing children's illnesses? What a great reflective question. And these are ones that you might want to take back to your service, have a conversation with your coordinator. Hopefully you've got lots of great information from tonight's session. You can have a conversation about working in isolation. How do we manage children's illness? Also thinking about what arrangements do we need to make for older children to independently administer their own medications. Now, if you've got school-age children, if you're maybe doing some USH care, it may be appropriate for those children to administer their own medication. And if we quickly jump back, there's actually a regulation about that. Regulation 96, self-administration of medication. Now, we need to be very mindful that we're only doing that if it's age appropriate, but having a look at what that might look like. You might have a child who's of an age where they can safely or correctly administer their own reliever or preventer. So having a look at what that looks like, you would still want to supervise. And lastly, who was consulted when developing the services policy on dealing with medical conditions, such as anaphylaxis and allergies? So did your service get some feedback from parents with diagnosed children, or did they consult a medical professional? Very good to think about where that information came from. The policies and procedures. Approved providers must ensure that you have policies for dealing with medical conditions, even if you have no children with a medical condition at the service. This is because circumstances can change, so it is one of the mandatory policies. New medical conditions can emerge and new children can enroll. Now, if you want some guidance for creating a managing medical conditions policy, you can find this on the ASEQA website. There's a great document about creating a policy around medical conditions. Okay, training requirements for educators. So each family daycare educator and family daycare educator assistant must hold current approved first aid qualification, which includes anaphylaxis management and emergency asthma management. So you need to have all three. Each family daycare educator and educator assistant must hold all three qualifications. So if you currently hold the HLT Aid 012, provide first aid in education and care setting, this contributes towards approved first aid, asthma and anaphylaxis training. So that's the three put together. Current industry standards recommend renewing this certification every 3 years, and the CPR component needs to be reviewed every 12 months. So ASCIA recommend that all staff should undertake anaphylaxis training at least every 2 years, preferably alternating e-training with face-to-face. You just get a bit more practical experience with the face-to-face training, especially they have mock auto injectors. So really good for you to be able to practice. So say you do an e-learning course this year, then you'd want to try and make your next refresher a face-to-face one. So there is a list of approved first aid qualifications and training on the ASEQA website, so you can have a look at that, and it's also mentioned in the booklet. There's great free online anaphylaxis training for childcare. So Askia has free anaphylaxis management training and refresher training for early childhood educators and carers. So the training provides a consistent approach to prevention, recognition, and emergency response of anaphylaxis. And this course is approved by ASEQA. So the training can be accessed on the allergy.org.au website, and you're looking for the early childhood anaphylaxis training. I'd also like to bring your attention to another course all about allergens for early childhood, and this is another free course. So you can visit foodallergytraining.org.au, foodallergytraining.org.au, and this course covers risk minimization techniques and practices in line with best practice, and it's specifically for early childhood education. So some really great training ideas there. We've got the free anaphylaxis training on the Askia, from Askia on allergy.org.au, and we've got the all about allergens for early childhood on foodallergytraining.org.au. Making sure that our first aid is always current. So when we enroll children with a medical condition, it's important that at the time of enrolment, it's really important to gather as much information around any child with a medical condition. So this marks the beginning of a partnership with a family. So from the very beginning, we want to make sure that we're working together with the family to provide really holistic care and promote an inclusive environment. As much as possible, we want the child to be included in a natural way. We want to foster friendships, relationships, all of those things. So during the enrolment process, have a conversation about any medical conditions, request the medical plans, develop a communication plan. So this might be between you, the GP, the specialist, the educator, the coordinator, whoever that is. Ensure you're clear and confident on how to administer medication. And if you're not sure, I'm positive that the parents or carers would much prefer you to ask and seek clarification than do any guessing. Ask the parents, if they feel that any supervision may be needing adjustment. Ensure confidentiality is maintained. Ensure you have a plan on how to manage the medical needs if you go on excursions or if you're transporting the children in any way, what that looks like at your service. Make sure you have clear policies and procedures around food handling or preparing food. Ensure families know how to communicate any changes. So if their circumstances change, they know how to communicate that. And develop procedures to ensure children never attend the service without their required medicine. So if the child is being dropped off, make sure the medication is with them. Making sure you have any necessary authorizations from the family. If you need to create a checklist, then you can do that. And what excursions and other out of the norm activities are going to look like. So as we finish up tonight, having a look at what to do after a medical emergency. So the final step in managing medical conditions is knowing what to do after a medical episode has occurred. So family daycare educators need to record any actions that were taken, any first aid given, any contact made with medical professionals or the parents, review the incident and discuss any areas of improvement. Replace any consumables. So if you used anything in your first aid kit or medications, making sure that they're restocked. Review the child's individualized action plan. Seek support or counselling if you need that. Now, under the national law and regulations, the approved provider must notify the regulatory authority within 24 hours of becoming aware of a serious incident. So this includes any incident involving serious illness of a child when the child is being educated and cared for, including asthma attacks, seizures, and anaphylaxis. So your approved provider would notify the authority of serious incidents through the NQIT system. And you will need to upload any completed documentation, so incident, injury, illness forms. There's a sample document, anaphylaxis incident reporting template on allergyaware.org.au. So that's something that you may want to look at about. You can contextualize it to your service about how to do reporting after a medical emergency. And here we have the plans that we looked at. So general asthma first aid plan, the individual asthma action plan, and there's some other supporting documents. So the school and child services action plan for asthma flare-ups. So documentation required for asthma. So there's several different plans there that we can use. There's the general asthma first aid plan. So your general asthma first aid plan provides a generalized first aid response. And then you've got your individual asthma action plan. So these are specific and unique for a child with a diagnosis. And then for anaphylaxis, we've got our Asthma Anaphylaxis action plan. So this is again standardized. This is a first aid response. And then you can also have specific ones for the child, an Asthma action plan for the specific child. And lastly, the site-specific anaphylaxis emergency response plan. So this document provides specific information about how the service will respond to suspected allergic reactions, including children with no known risk of anaphylaxis. Now, documentation required for both asthma and anaphylaxis, that is our medical management plan or our Asthma action plan, very important, which we've spoken about. Now, another good point to be aware of is that Asthma action plans, they don't actually expire. So the plan is still valid beyond the date of review. That date of review is simply a guide for patients to see their doctor or nurse practitioner. So definitely best practice to have it reviewed on those dates, but it doesn't expire as such. You can still reference that plan. We need to have a risk management plan according to Regulation 90. So risk minimization. Risk minimization plans are required under Regulation 90. It's important for us to do risk minimization plans for common medical conditions, such as allergies, asthma, family daycare. For family daycare, it's very important to consider the varying physical capabilities of children that you might have, especially if you've got mixed age groups. So the plan should be developed in consultation with parents or carers, reviewed and updated regularly. So it's really looking at how you're going to try and reduce any exposure to risk or triggers in the environment. We then have our communication plan, which shows how information will be kept up to date, how we're going to communicate with our families. And then other forms include medication authorization form, and there is a template available from ASEQA, and I'm going to show you it on the next slide. That's where we get parental consent to administer medication. Incident injury trauma form. So that's our usual incident injury illness form. We fill that in anytime a child has an illness. An individual care plan. So they're not a requirement under national law and regulation, but these plans can complement individual action plans. So there's something that can be looked at. But this is an example from ASEQA of the medication record form. So this is where the parent gives us consent to administer medication and gives us all the details, like the expiry date, when it was last administered, how it's to be administered, the dosage, and then we complete the other side once it's been administered. And then our incident injury, trauma or illness form. This is the information that must be in that form. So the name of the child, circumstances leading up to the incident injury. Most services will use the ASEQUA template and maybe tweak it slightly or contextualize it to their service. Okay, we're frantically running out of time here. I didn't realize how late it had got. It's a very big topic and a very important topic. So I hope you've learnt a lot with that. We're now just going to do a really quick poll. So we've done this for our last few sessions. I'm going to pop that poll up now and give you a few minutes to complete that. And then I'll share the results with the group. So everyone should be able to see that poll now. There's just 6 questions. If you want to have a quick look through everything that we've discussed tonight and answer those, I'll only give you a few minutes because I don't want to keep you much longer. And then we'll see if we have some time for a few questions. Okay, I might close up that poll now because I am very conscious that we've gone over a little bit. Okay, so I'm sharing the results with you now. So wheezing and coughing can be very common in preschool age children, but do not always indicate the presence of asthma. So that one is true. Well done. What are triggers for asthma flare-ups? So exercise, pollen, cold air, feeling stress, and of course it was all of the above. Well done. Adrenaline auto-injectors such as EpiPen should be stored in a locked cupboard. False. Oh, we got lots of truths there. So adrenaline auto-injectors such as EpiPens should not be in a locked cupboard. They are exempt from being locked. We need to have them very easily accessible. So making sure that we remember that in an emergency, we don't want them being locked up. Each family daycare educator and educator assistant must hold first aid, asthma and anaphylaxis training. True, great. And the National Allergy Council Best Practice Guidelines recommends that all early childhood education and care service, including family daycare educators, consider purchasing an adrenaline injector for general use. And that was one of the questions that was asked, who recommended that? So it's the National Allergy Council Best Practice Guidelines. And last question, side effects experienced after the administration of relievers and preventers for asthma is uncommon, very mild, and not dangerous, which is true. So well done, everyone. Fantastic work there. So that brings us to the end of our session. Because we have gone over tonight, there didn't seem to be many questions. There was just one that I was looking at. If a child is diagnosed with a condition, a medical condition, or is diagnosed with asthma, and their action plan mentions 2 different kinds of medication, but the parent's only bringing in Ventolin, so one medication that's mentioned on the plan is not being provided, what to do. So absolutely just have a conversation with the parent. If any of your plans are mentioning a medication that's not being brought in, it may be because it's not suitable for the day or it's not prescribed. but just having that conversation with the parents. So if you're unsure about anything to do with a child's medical condition, making sure that we have that good partnership and we have open communication. So we're really having that conversation and just saying, I want to make sure that I'm providing your child with the best care. So can I ask some questions? Now, if you do have any questions later on, as always, you're very welcome to email us. Or I also encourage you to use the PD in Your Pocket Facebook group. Really good way, as we mentioned, to network with other educators. And most of the time we see educators answering each other's questions, and that's fantastic. So that brings us to the end of the session. My apologies again for going a little bit over time, but I hope you found it really beneficial. There was so much to look at tonight. It was a very big topic, but a very important one. So I hope you've learned a lot. You can watch the recording or access the booklet and interview on the website soon. It will be up in the next few days. This project is funded by the New South Wales Department of Education through the Sector Development Program. So fantastic that this is, PD in Your Pocket is still being funded for its 3rd year. Very exciting. Please remember, again, Facebook group, please join if you haven't already. And I look forward to seeing everyone next month for another fantastic topic. I have loved being with you this evening and sharing all this information, and I hope you have a lovely rest of your evening. Goodbye, everyone. See you next time.